All right, good afternoon. We'll just give it a moment for everyone to join us. All right, as you are logging in, we'd love to welcome you to our system-wide Grand Rounds. Thank you so much for joining us. My name is Francesca Varallo-Sims. I oversee education and training for behavioral health. Before we begin today, just a few notes on today's presentation. If you do have any questions, please submit these into the Q&A box or directly into the chat, both of which will be monitored. At this time, if you're logging in through a cell phone and not an official Teams account that states your name, please sign into the chat in order to get continuing education credit. Like I noted, we will be monitoring this in addition to our email inbox, and you can email us with any questions or concerns at grandrounds@bmcjax.com should any questions arise as we go. I'd now like to introduce our speaker for today, Dr. Aryeh Shander, and he is Emeritus Chair of the Department of Anesthesiology and Critical Care Medicine at Englewood Health in Englewood, New Jersey. He holds academic appointments as adjunct clinical professor in the departments of anesthesiology, medicine, and surgery at the Icahn School of Medicine, Mount Sinai. He is the clinical professor of anesthesiology at Rutgers, New Jersey Medical School, and adjunct clinical professor of anesthesiology at the University of Florida. Dr. Shander previously served as executive medical director of the Institute for Patient Blood Management and Bloodless Medicine and Surgery at Englewood Hospital and is a past president of the Society for the Advancement of Patient Blood Management. He lectures nationally and internationally on a variety of topics and has authored more than 230 peer-reviewed publications, along with numerous book chapters and textbooks. We're so honored. Thank you so much for being here, Dr. Shander. The floor is yours.
Thank you so much, Francesca, for this wonderful introduction. Good afternoon, everyone. We'll start because we have a lot of material to cover. So as you see, the title of this talk is Patient Blood Management, what it is and what it isn't. And what I'd like to do, this is just to start with, is my disclosure slide that you could, again, get more information from Francesca if you need it. So there is some confusion when it comes to blood, especially as a therapeutic intervention, which transfusion are. So it's transfusion, as you could see, is the only treatment for many patients, and we generally use laboratory values to treat patients when it comes to transfusion rather than the clinical picture. So I will elaborate on why we have a problem and why we need to change the status quo. Then we move on to defining the unmet need. And the unmet need is really looking at some hematological problems or diseases that we have that need to be addressed like we address everything else, which is we need to make a diagnosis, provide the appropriate therapy for patients. Again, that's sort of coined, if you will, as the unmet need. Then we'll move on to defining patient blood management versus what's called OBU. Again, OBU is optimal blood use, which is what people talk about when they talk about reducing transfusion. And then we'll show some data in terms of patient blood management, and we'll end up with where we are in terms of directions for patient blood management. So as you see from this slide, transfusion for the medical community is a treatment for anemia, and it unfortunately remains a default position. We have anemic patients in the hospital. If they reach a certain hemoglobin level, they get transfused. What's interesting also that about 3/4 of patients admitted to U.S. hospitals are already anemic on admission, and we continue to make them anemic until they reach that threshold. And then what we do is we replenish their blood with someone else's blood from the blood bank. My good colleague, as you see, reference Steve Frank from Hopkins, tried to explain to the American Society of Anesthesiologists at 2021 the difference between transfusion medicine and patient blood management. And the way he coined it was that the blood saves lives when you need it. That's transfusion medicine. And blood only increases risks and costs when you don't need it. And that's how he defined patient blood management. And I think we need to examine that because I don't think that's very accurate. So there's a sort of a confusing message here. And one of them, which I review from many journals that you had, is that blood saves lives. In fact, the blood is used as one of the parts of the armamentarium where we do treat bleeding patients, but also patients who are anemic or patients who have coagulopathy. Blood may not actually save lives as it does. And this actually was coined during World War II by Madison Avenue as a jingle to get donors rather than have any basis in terms of factual or evidence base. So we go back to this definition of Steve Frank in terms of patient blood management versus transfusion medicine. So we go back and say blood saves lives when you need it. Well, the big question is, when do you need it? And we've published this in 2011, asking the question, what is really dangerous, anemia transfusion? The idea behind this particular slide is to show that anemia is an independent risk factor and that transfusion, again, do carry risk. But when you put the two together, as I will develop in the few slides that are coming, you could see that the risk is synergistic between both anemia and transfusion. Now, the other problem is when you need it. And this particular publication, which I like to use, I know it's pretty old, it's from the 1990s, but I think this gave us a window into the fact that transfusions were more a cultural event rather than evidence-based. And what they looked at as surgeons, and what they found at the end of this particular survey of the surgeons, is the amount of transfused product was inversely proportional to physician knowledge of transfusion medicine or blood. In fact, what you're seeing here is the more you know, the less you give, the less you know, the more you give. Clearly cultural and not something which is evidence-based. This brings us also to the fact that there's overuse in transfusion. This comes from the proceedings for the National Summit on Overuse. This was put together by the Joint Commission and AMA. This is no endorsement of either. And they looked at 5 areas in medicine: elective percutaneous coronary intervention, myringotomy in tubes, early cesarean sections, and antimicrobial therapy in upper respiratory infection. And you could see that transfusion medicine was also on the list. These are just 5 of many, but these that were selected. There's no hierarchy in terms of these particular ones. And overuse was defined by the Institute of Medicine, which today is the College of Medicine, in 1980, as the use of health services in circumstances where the likelihood of benefit is negligible and therefore the patient faces only the risk of harm. If you cannot define any benefit, or you can't demonstrate any benefit, the only thing you're doing to a patient, whether it's a procedure or intervention, any intervention, is introducing risk. Now, again, defined overuse of in healthcare services. We know that it does harm to patient when it's overused. There's excess cost to society. It defies patient preference. No one wants something done to them, which is only risk, no benefit. So therefore, it affects healthcare quality, and this becomes a patient safety concern. So you can see all this is building now to the fact that blood saves lives may be questionable, especially when you need it, is another question which we can answer. What's interesting is when we did the Overuse Summit, we looked at the literature, and what we found was that overuse was defined as inappropriate transfusion. And when you look at the publications, it shows anywhere from 40 to 60% of inappropriate RBC transfusions. So 6 out of 10 transfusion are inappropriate or just overuse. They don't show any benefit to patients, therefore there could be just risk. However, if you look at hospitals that introduced ways to reduce transfusions, you could see reduction from 12 to 83%. So we could say that 8 here out of 10 transfusions were unnecessary. A reduction from 9 to 77%, again, a significant overuse. And plasma here was 85% reduction. None of these were associated with any harm to patients by reducing these transfusions, showing that the transfusion either had no benefit or had some risk through the patients. We also know that blood transfusions still are very highly again regarded as a high frequency procedure in the United States. This comes from AHRQ. The blood transfusion occurred in 1 of 10 of all hospital stays that had a procedure performed. I would say that probably at the time this was published, this was an underestimate because we make patients anemic and then we transfuse them. Now, we've had data, and I know that this is a very hot topic today, but keep in mind that when we have a hot topic, what we need to do is look at the totality of evidence, not just the last publication. So this looks at the relationship of blood transfusion and clinical outcomes in patients with acute coronary syndrome, published in 2004 by Sunil Rao, who, by the way, is still publishing on this issue to date. You could see that the patients were taken from large randomized controlled trials. And again, what this is demonstrating that transfusion was associated with a cumulative mortality of patients as you go along the x-axis with the number of days. So we know that this is not always a positive effect on patients in terms of saving lives. Here's the risk. And here's another one that followed, the American Journal of Cardiology by Aronson et al., again showing the same, this was retrospective, but showing again the same Kaplan-Meier graph of worse outcome with transfusion versus non-transfusion. Now, some of you would say that the non-transfused were less sick and the transfused were sicker, therefore they got transfused. Well, if that is the case and transfusion were that beneficial, wouldn't the transfused patients do just as well as the non-transfused because they were sicker? The transfused would help the sickness and make them equal, if you will, to the non-transfused. But there is also data that that's not the case. Here's another large cohort of patients looking at preoperative anemia versus blood transfusion. Remember the synergistic effect of transfusion and anemia. And here they looked at mortality, renal failure, and stroke. And what they were able to demonstrate is that as your anemia got worse, it's almost linear, so does your prediction of mortality. The same thing is that as your anemia gets worse, your likelihood of being transfused also increases almost in linear fashion. And lo and behold, when you look at clinical outcome, this one looked at AKI, acute kidney injury, you see again that it's clearly related to worse outcome with both. The editorial that followed this particular article said that anemia is bad, transfusion is worse, and both together are worse than either one alone. Again, the synergistic effect. We're moving away again from transfusion saves lives to maybe being a risky procedure. This is across the board from birth to death. So here's the pediatric population showing again going for bloody surgery. On the left, you see no anemia. You see the risk of mortality is very low. Anemia already increases the risk almost 4 times. No anemia and transfusion show you the same mortality as anemia. But when you combine the anemia and transfusion, you see what happens on the right side of the slide. So this story is told over and over again. Here's another publication looking at 450 clinical scenarios where patients who are hospitalized get transfused. The definition was, according to Rand Delphi, appropriate was at improved health, inappropriate was uncertain, and inappropriate was reduced health, and uncertain there was no benefit. And you see that close to 89%, 81% of patients transfused had either no benefit or actually worsened their health. Only about 12% of patients had improved health, and that's mostly in oncology patients who are transfusion dependent. We talked about the fact that transfusions were a cultural event, and that we also said that sicker patients were more likely to be transfused. But I think that there's very good data now showing that that's not the case, going back to the fact that transfusions are mostly cultural. This is coronary artery bypass graft done in 30 patients in 18 institutions. And all these patients were matched, including their blood loss. And you could see that if you were admitted to hospital number 1 on the left, the rate of transfusion was significantly lower as compared to hospital number 18, where all the patients were transfused. The clinicians would say that they were sicker, but in fact, we know that this is cultural. This was repeated again and again. This one is from 2010 in JAMA, looking at a large number of institutions, close to 800 in the United States. Coronary artery bypass grafting. You could see on top, 100% of the patients in these hospitals were transfused as compared to close to zero in other hospitals or less than 20%. This is found to be, again, the variation in transfusions were not due to differences in patient acuity. The transfused patients, some of the variation is due to differences in how patient blood is managed, anemia treatment, avoiding blood loss, and inappropriate transfusion threshold. Again, where is it that blood saves lives is still the question. This is not restricted to cardiac surgery. This shows you again that this is an orthopedic surgery, and we have many other data out there, but because of time, I can only just show you a few snippets of this particular wide literature. Now we go back to the blood industry to confirm our suspicion. And this is ISBT, the International Society for Blood Transfusion, a publication in 2018. It's titled Blood Transfusion, 1 Unit Too Much or 1 Unit Too Few. Which strategy poses the smallest risk to patients? Notice they're not asking anything about benefit. And here again, they're stating, and this is verbatim, the best transfusion strategy and the optimal dosing for packed red cells are still missing in most indications. Sufficiently powered prospective randomized controlled clinical transfusion trials for packed red cell in most clinical settings are urgently needed to reduce ill-founded clinical decisions and base transfusion strategies in clinical evidence and scientific study results. These are calling for prospective randomized controlled trials, which we're not going to see. We're seeing randomized controlled trials on liberal versus restrictive transfusion, which is not what they're talking about. They're talking about the clinical indications for transfusions. And as I mentioned, there's nothing about the benefit. We know that this has been shown in many, I'm not going to dwell on this slide, but just to show you again that the combination of anemia and transfusion have the worst outcome across all of those on the y-axis that you're seeing listed on the slide. And we know that even this is dose dependent, that even a single unit of blood, as from this publication coming out of New York in 2023, showing that a single unit of blood raises your adverse events, such as operative mortality, stroke, sternal wound infections, prolonged ventilation, new hemodialysis, and reoperations. So all in all, we're seeing that transfusions don't necessarily benefit patients, actually represent risk. Now, what's interesting is this particular publication in the last one in 2013. And by the way, almost every 10 years or few years, we have new guidelines, of which 70% are produced by the blood industry. Now, we don't have that in antibiotics and anywhere else. So keep the back of your mind that the industry that actually provides you with the blood is actually making the recommendations when to use it. But the reason I'm showing you this table is that notice that there's no number in quite a few of them. That's because these are sophisticated enough to know that a hemoglobin alone is not enough, because hemoglobin is a concentration which may vary, and therefore using 7 grams or 70 grams per liter is not an absolute number. It's a relative number. You could be 7 in the morning and 8 at night, or you could be 8 at night and 7 in the morning, depending on where you're examining the patient. Which brings us to the definition of anemia. And unfortunately, we're still using what's called the WHO definition, which is pretty old and should be retired. But these are arbitrary cutoffs for men in red at 13 grams per deciliter or less. And for women, it's at 12 grams per deciliter or less. I will tell you again, these are arbitrary cutoffs. The problem is that hemoglobin, as you see, is grams per deciliter, which is a concentration. The absolute number is the red cell mass. So the red cell mass differs between women and men, and therefore the hemoglobin concentration should be the same. So we should have 13 grams for everyone, not just for men, but across the board, recognizing that the red cell mass may differ between women and men. Let me show you what happens with a hemoglobin. This is a red cell mass, which is normal. You could see on top what it's reading. Here's a normal hemoglobin of 13 grams per deciliter. If your plasma volume is high, you can go down to 11. If there anyone from the laboratory here, they will corroborate that's your standard deviation. If your plasma volume is low, you can go up to 15 grams per deciliter. Take a look at the divergence from 13 grams per deciliter, again making the point that this is a concentration, not an absolute number. Now, if you take someone who has a reduced red cell mass, we're talking here about 30%, here's your hemoglobin is 9.0 grams per deciliter. If your plasma volume is low or is reduced, you can be as high as 11 grams per deciliter. But if your plasma volume is high, you could be as low as 7 grams per deciliter, which is where the threshold for transfusion is, despite the fact that there's been no change here in the red cell mass. Note that. So here we are using a number to treat patients, which is not absolute, extremely relative, and does not reflect the red cell mass. And unfortunately, we use that because we can't do a red cell mass assessment non-invasively. It takes actually quite a while. So until we have a non-invasive way of doing it, we're strapped with hemoglobin. We still need to understand the pitfalls of using hemoglobin as a single number, which is, by the way, used in these trials of restrictive versus liberal transfusion. And you could see how faulty that estimate is. Now, there are some other, I'm not going to dwell on this either, but here again, looking at the variability of transfusion practice, and this is from the UK and Canada, but you could see again the search to understand the prescription of transfusion as a therapeutic agent is still a question. So when we need it is still very much an unanswered question, which brings us to patient blood management. And here's a definition by the blood establishment. This is the ABB definition of patient blood management. They're saying the appropriate provision and use of blood, its components and derivatives, and strategies to reduce or avoid the need for blood transfusion with the ultimate goal of improving patient outcome. Unfortunately, as you see, this is transfusion focused. It's therapy based, meaning calling blood a therapy. It is not addressing anything about the patient itself, nor is it addressing the cause of the anemia. So patient blood management brings the solution because RBC transfusion is a therapy and we need to understand what it is that we're treating. I could stand here for the whole time that I'm speaking to you talking about talking about transfusion without ever talking about the disease we're treating. If I did the same with insulin with never mentioning diabetes, it would be sort of odd. So the disease that red cell treat, excuse me, happens to be anemia. Now, for the sake of the talk and time, we're not including plasma and platelets and cryo. What is the epidemiology of anemia? In the beginning of 2015, the World Health Organization declared the world population to be in excess of 8 billion people, of which more than 2.5 billion suffer with anemia. This is the fourth leading cause of years lived with disability in the world. By the way, what's the other three? Cancer, diabetes, and heart disease. So now we have the club of four, if you will. And iron deficiency affects more than 1.5 billion people. And the ones that are mostly affected by anemia happen to be women at all ages, children less the age of 5. And now what's growing is we're recognizing the elderly is increasing in the number. Now, what I'm showing you in this particular slide is the green. The green in the center represents iron deficiency anemia. It's a disease that's easy to diagnose. It's a disease or to screen for, easy to diagnose, and easy to treat with more than 95% recovery or cure rate if we take care of the underlying condition. So this is a nutritional anemia. All the other causes that you see on this slide are all other causes of anemia, whether it be hereditary or nutrition. One thing that's surfaced over the years is the fact that you start off by being iron deficient before you have iron deficiency anemia. And here is data from Spain by Manuel Munoz looking at alterations in iron status in patients going for surgery. On the left side of the slide, these are non-anemic. The black bars represent absolute iron deficiency, and you see the prevalence of absolute iron deficiency is not zero in this population. Mind you, they're not anemic, but they're iron deficient. On the other side, they're anemic, and you could see again the prevalence of iron deficiency is pretty high. So I'm not going to spend a lot of time here on this, but the point again that I wanted to bring to you is that we're now recognizing that iron deficiency alone may carry risk for surgical patients and may actually have risks for all patients, including, by the way, their parturients with a developing fetus, because there's now burgeoning data on the fact that brain development in the fetus is tied to iron and iron availability. The restrictive versus liberal transfusion trials have been out there. And again, I don't think that we've seen any difference in their outcome. They're showing either no difference or sometimes they're manipulated to show that there may be a risk in the restrictive or benefit in the liberal. But the fact of the matter is, to date, we're seeing absolutely no difference between the two. But again, keep in mind that these are transfusion and they're only as a one single therapy. And again, when you lose blood, you become iron deficient. And the low rates of diagnosis of treatment of iron deficiency anemia after acute severe gastrointestinal hemorrhage is pretty low, as you see from this slide. Again, 337 patients. The diagnosis and the treatment is, again, below what I would consider standard. I did mention to you the fact that patients get admitted to hospitals in the United States. About 3 out of 4 have anemia. This was data from the Cleveland Clinic showing mild, moderate, and severe anemia. And you see that this is tied to increased mortality as the anemia gets worse, length of stay, as well as hospital charges for patients. Large cohort, close to, again, 1/5 of a million admissions in 10 hospitals. And that's because we keep taking blood from patients, which may be unnecessary. Data from you showing that each year about 25 million liters of patients' blood is thrown into the waste containers. And this is because we do repeated standing orders for blood, which are unnecessary because there's data showing that that does not affect our clinical decision, but in many situations. This is one of them illustrating that unnecessary labs, and what it's showing that every day a patient is hospitalized, the value of repeated blood tests goes down by 20%, meaning that by day 5, it is zero. The only 2 laboratories that have value unrepeated are potassium for those patients who have developing acute kidney injury and blood sugar for the diabetic patient. So we moved back to patient blood management as mentioned, and I would start off by saying that patient blood management is not about blood transfusion, it's about patient outcome. And it said patient blood management is not centered on transfusional blood components and certainly not on red cells. Patient blood management is centered on patients, more specifically on those who undergo major surgical or major medical procedures that put them at increased risk of complication and mortality. So we are actually identifying risk of patients with anemia, coagulation of blood loss, and working on that. In 2021, the WHO has published this policy brief. Those of you who are familiar with the WHO policy brief know that they're not brief. This is the urgent need to implement patient blood management. And what they were talking about here is using optimal use of blood, trying to separate the two concepts from one from another, meaning reduction of transfusion is not patient blood management. Which brings us to the definition of patient blood management by patient blood management experts. Rather than what you saw before, which was the AABB patient blood management definition. And here, patient blood management is a patient centered, systematic, evidence-based approach to improve patient outcome by managing and preserving a patient's own blood while promoting patient safety and empowerment. Nothing about transfusion. Why patient's own blood? Because blood as an organ, which is a liquid organ, can completely regenerate if we give it the opportunity and the nutrients it needs to do so. There's nothing better than patient's own blood to do whatever it needs to do, whether it's immunity, whether it's oxygen delivery, whether it's getting rid of waste. All that is done much more effectively with the patient's own blood than it is from any red cells coming in from the blood bank, which again don't only have an anatomic change, but also biological and chemical changes to them. So rather than having pillars, the Society for the Advancement of Patient Blood Management came out with a four-leaf clover. And you could see that here it's management of anemia, which is central to patient blood management. Interdisciplinary blood conservation modality. Everybody thinks in terms of blood loss during surgery, but I showed you majority of blood is coming out of phlebotomy, which is unnecessary. We need to change that also. Optimizing coagulation. This is another central theme in patient blood management. And what's added here is patient-centered decision-making, which is not the patient making the decisions about the healthcare. It's about a team approach to the patient's health in terms of aligning the goals of the patient with the goals of the team and making sure that the patient's needs are met rather than just a paternalistic view of what needs to be done to the patient. This is just a demonstration of the different amount of tools that are available in patient blood management compared to transfusion. Now, transfusion is on this list, but way down as the last, and you'll see why as we move along. And there have been publications looking at prevention, diagnosis, and management throughout the spectrum of preoperative care, but also for medical patients. This is one of the algorithms that has been produced. There have been multiple of them from the early 90s and still being produced today. There are some changes in terms of accuracy of diagnosis, which is improving in terms of the laboratory tests for levels of iron, as an example. But I don't know if you could see this in the background. Oh, I'm sorry, you could see it in the background, but the top box starts off with educating the patient. This is, again, the most important step, because if the patient understands what it is that we are diagnosing and what needs to be done, they become a partner. We're not fighting, and they actually have a much better outcome and adhere to the therapeutic interventions, which are now part of their goal as well as ours. As far as outcome data, this is one that's in this particular publication from the WHO. This is what's called the Western Australian Project. This was funded by the Western Australian government, the Ministry of Health, 600 hospitals. I'm sorry, all the hospitals in Western Australia with over 600,000 patients. And here, what they showed after implementation of patient blood management was improved patient outcomes, reduction in mortality, 28%, infection, 21%, acute myocardial infarction or any cardiovascular events, 31%, length of stay of 15% reduction. A key performance indicators, such as patients going to surgery with anemia, dropped by 14%, reduction of the threshold of hemoglobin transfusion down to 7.3 or 73 grams per liter. Single unit from double unit transfusion went up by 64%. And then you could see the spin-off of patient blood management is a reduction in blood transfusion, 41% for red cell, 47% for plasma, 27% for platelets. And lo and behold, you could see the enormous savings in tens of millions of Australian dollars that could be repurposed in the health system. Same in Canada. This is 20-year history of coordinated patient blood management in these hospitals in Ontario. A reduction in transfusion. This is hospital length of stay, both reduced and sustained. Reduction of infection. You could see no transfusion in the gray, transfused in the white. The gray non-transfusion is not just non-transfusion. These are patients on track protocol for treatment of anemia, the coagulation, and bleeding. And lo and behold, significant savings to, again, the health division of the government of Australia. I'm sorry, of Ontario. Now, there's been some talk about the fact that iron deficiency anemia. So this looked at a prospective match cohort study of intravenous iron versus red cells for preoperative iron deficiency anemia. This came again out of Hopkins. You could see as a senior author, Steve Frank, where I showed you before. I'm not going to go through the table because I think it's very difficult, but the fact of the matter is that if you look at any of the negative adverse events that occur, that transfusion of red cells clearly have a worse outcome at all levels compared to iron replenishment for iron deficiency anemia. Well, you may ask why. My answer would be because when you use the appropriate therapy for the underlying disease, you're going to get better benefit with less risk. And the same goes for erythropoietin with or without iron. This is another same first author showing again the data here where when you're looking at RBC transfusion versus ESA and iron or ESA ESA and iron or ESA without iron, you see again that for each one of these, RBC transfusion had worse outcome in the tables below. So we're back to asking what is patient blood management versus optimal blood use, PBM versus OBU. So PBM focuses on person-centered decision-making and blood health. OBU focuses on transfusion-related decision-making. Patient blood management promotes therapies for anemia, bleeding, and coagulation. OBU promotes evidence-based transfusion practice, and you saw that already evidence-based is not one of the characteristics of transfusion medicine. PBM employs informed choice because patients do have a choice to either accept or decline, whereas here we employ with OBU informed consent. And you know that there's a lot of trouble with informed consent and how we achieve it and how we get it. And most of the time, we just ask the patient to sign the form. PBM seeks to protect and build person's own blood, and you see that OBU seeks to improve blood component utilization. And the goal here of patient blood management is improved blood health as compared to OBU, which is minimum effective dose of blood components, of which many of the times we don't know what they are. And many times, if there's no benefit, there only are risk. These are just a summary quickly of the opportunities that PBM brings to patients: and mortality reduction, reduced length of stay, reduction in readmission, reduction in composite morbidity, as well as infection rate, reoperation, as well as overall cost. And the spin-off, of course, is a reduction of transfusion anywhere from 10 to 95%. So we have a problem that transfusion medicine cannot answer, and that is patient blood management does. And again, the issue, of course, is that we need to reverse the status quo. Blood is a liquid organ, whether you like it or not. And again, when we do care for patients in terms of their organ health, if it's a solid organ, whether it be kidneys, lungs, anywhere in our body, the last thing we offer those patients is a transplant. However, if blood is an organ, transfusion becomes a liquid transplant, and that's generally the first thing we offer. So we need to reverse that and start thinking in terms of blood health. So blood health is the optimal function of individual elements of blood and their associated interactions with all other organs and organ systems. A patient blood should be managed like any other organ system with the aim of improving blood health and global health outcomes. This concept was again developed by Sherry Ozawa, who happens to be a patient blood management nurse. This has already been published this past year in Anesthesia and Analgesia. So the aim, of course, is blood health, the way we look at kidney health, the way we look at all other organ health in our body. And in fact, that is the goal of patient blood management, which can achieve it, whereas transfusion medicine cannot. So with that, I'll stop and see if there are any questions, rebuttal, debate, whatever it is you would like. So thank you for the opportunity of your time.
All right. Thank you so much, Dr. Shander. All right. So for any questions from the group that's with us, please put them into the chat. I do have a couple, though, before we share our CME information for our attendees. So the first question, Dr. Shander, despite all of this research, tons of randomized clinical trials and society guidelines that support restrictive transfusion thresholds, what is your thoughts on why adoption remains inconsistent in clinical practice? And second part, if there's strategies that have been effective in closing the evidence practice gap.
This is a big question in terms of adoption, implementation and adoption. So I've been asked this question quite frequently, and actually I give a talk in some of the seminars across the world on that. And what I'd like to do is to step away from patient blood management, because most hospital administrators, as well as ministries of health, are inundated with problems, healthcare problems. We are basically centering on one of them, which is blood and patient blood management. So we don't have the priority, if you will. So keep that in mind. But let's step aside. Let's look at other events where mortality clearly is a major issue. And all of you would be familiar with the fact that we have sepsis campaigns out there and antibiotic stewardship, right? These are all issues which are very similar, meaning we're fighting the status quo and also a bit of paternalism. You can't tell me what antibiotic I should order. Although over time, I will tell you, clinicians have adopted to the fact that if the antibiotic is inappropriate, that the pharmacy can actually change that. In sepsis, as an example, we know it's a bundle, just like patient blood management. And when we look at the data that's been published in terms of adoption, all of the sepsis campaigns show less than 50% adoption, and we're constantly fighting it. So bringing the outside world into patient blood management is something that you as a clinician need to know that this is right for patient. You need to adopt it. Your colleagues, some of them will come with you, others may not. But the fact is that this is an ongoing process that may require actually generation before we achieve a change in the status quo. Additionally to that, you see that the blood establishment is out there providing blood, right? And providing guidelines too. So it's much easier to transfuse a patient than to start doing tests for iron levels and start treating them with iron. Although once you do it, you see how easy it is, and it's just as easy and much more rational than giving a blood transfusion for those patients who are anemic. So, it's not a quick answer, but the fact of the matter is that you need to be patient and you need to be an adopter before you could see this being adopted across the board. The same way with antibiotic stewardship, sepsis, and other areas where they're bundle of care.
Thank you. And, on that note, in terms of treating or identifying anemia, we know that that's the disease and the transfusion is the intervention based on your talk today. What are the most underutilized opportunities to diagnose and treat anemia earlier, particularly in preoperative patients, would you say?
So there have been many publications on this, and there's a lot of data out there. But I think that we need to manage the data with some realism, right? So the fact is that for surgical patients, we know that anemia increases the risk of negative outcome, and transfusion are synergistic. So if we're going to assess patients going to surgery for the underlying risks that are modifiable, age is not. I'm not going to go into the sex part, but age is not. But the fact of the matter is that anemia is modifiable risk, and so is transfusion. So the best time is to get patients who are going for surgery, elective surgery. We know the ideal time is 30 days prior to surgery. That gives you an opportunity to make a full diagnosis, also gives you an opportunity to give them full treatment, an opportunity for you to get their hemoglobin up to normal. Now, the reality is that so many patients may not have 30 days. Now, if you're very committed to making sure that all risks that are modifiable are attended to, whether it be cardiac, whether it be pulmonary, whether it be endocrine, or whether it be hematologic, they should get that, and we should postpone surgery for elective surgery if the patient is anemic to treat them. However, sometimes that's not feasible. So we have data that any day prior to surgery, if the patient is iron deficient, they get iron, they do better than if they didn't. Now, it's not ideal, but it is something that we could do. Now, even if you recognize that the patient is in surgery, including fracture surgery, which are urgent, or even emergency surgery, if you know your patient is iron deficient, there's no reason not to give them iron. And if they tolerate their anemia, it doesn't matter what the number is, and they're iron deficient and they have iron deficiency anemia, iron is a proper therapy. Clearly, if they're unstable, many of my colleagues will say a transfusion may help. Again, the saving of the lives is a concert. It's not one product. Even in trauma, blood does not save the lives. It's the surgeons, it's the nurses, it's the anesthesiologists, it's the critical care, it's everyone, the ambulance, everyone together is what saves the lives, not a single product or component. So ideally, 30 days prior to elective surgery. We'll take any time before. Don't think that it's too late to treat even 3 days prior to surgery.
Thank you.
So I'll just add that if you have two patients who are identical, both having hemoglobin of 9, both are iron deficient, going for surgery, the one who's received iron is not the same as the one who has not received iron, because that one who's received iron with the same hemoglobin, same patient or identical patient, will again have their bone marrow already supplying and their blood supplying iron to red cells. So they're already ahead of the game as compared to the other one who has got their factory is just not geared up to face the increased risk of surgery, which is, by the way, an inflammatory process.
Wow. I mean, it probably would not be, a protocol for everyone to get iron, but it sounds like it might be beneficial for, everyone's iron to be evaluated prior to that.
Right. You need to make the diagnosis of the anemia and then to know
Mhm.
the etiology, the cause of the anemia. And if it's iron deficiency, which I showed you is the most prevalent, that's what we use it as an example. But it could be inflammatory anemia where EPO and iron need to be given,
Okay.
or B12 deficiency.
Man, it is so complex and nuanced, but I'm appreciative of you providing this information and thinking about areas of research that need more attention, to further this body of work. What do you feel is missing currently from the literature?
Well, what's missing, of course, is a transfusion versus a protocol treatment rather than liberal versus restrictive. If we take patients now, we're starting to see some of that with iron, as I showed you before, but we need to have prospective randomized clinical trials on the appropriate treatment of the anemia, depending on what the diagnosis shows the etiology is, versus a transfusion, which is a single intervention in terms of outcome. I don't know that the NIH or any of the blood establishments would be willing to support that.
Yeah. Gotcha. So some external barriers kind of outside of our control. We have a question from James Webster. Transplant teams, such as for lungs and liver, use the reasoning that due to a limited number of organs available to them for transplants and more patients needing them, then it is unethical for them to accept a patient with restrictions on the use of blood. They say this even when they are doing some of their transplants without the use of blood. What are your thoughts on that reasoning?
Um, my thoughts is that we already have sufficient data showing that these operations in these patients are successful. So transplant in patients for whom blood is not an option will occur. And those patients should have the same opportunity because we have data showing that they're successful as everyone else. You know, we do a lot of things to other people whose chances of survival are much lower, combatants, trauma injuries in civilian life. I can go down the list where we do things, again, not thinking that there's an ethical problem there, right? But the fact of the matter is that there isn't an ethical problem in my mind. I think that you select your patients. I don't think you take moribund patients to transplant surgery. I think you take people who have a chance of recovering from their underlying disease with a operating organ. But the surgery itself can be and has been, and there are places where we actually send patients to because they will do the transplant surgery and they're successful.
And just one final question for you, Dr. Shander. So, your presentation highlights the significant inter-provider and inter-institutional variability that exists in transfusion practices, right? You noted how it is a cultural, way to go about things, not necessarily based in the evidence. And so, what educational or even system level interventions have you seen in your experience that have helped standardize care related to blood management without compromising clinical judgment?
So I will tell you that what we have generally, and it's a requirement of the Joint Commission, which I know was visiting here, that you review transfusions in terms of quote unquote appropriate transfusion threshold versus not, right? You could use whatever you want, but that's what they want you to do is review them. That's a retrospective review, which is the event has already occurred, and many times that's sort of a an activity which is more ritualistic than actually provides any kind of change in practice. Prospective review, meaning that the blood's not going to be released. The component of blood will not be released from the blood bank because after prospective review, this patient is not being appropriately managed. And those hospitals, and there are a few in this country and a few around the world, where prospective review is done by transfusion or blood bankers, which are specialists in transfusion medicine. And if they find that there is absolutely no rationale for the transfusion, will not release the blood components. And that has changed practice significantly. And guess what? There's also an exchange because the transfusion specialists can't just say, I'm not giving it to you. They need to, again, base their clinical decision on evidence. And that's where the learning occurs between them and the clinician who ordered the blood. Now, not everybody learns from encounters, but in many situations we do. So that enriches the individual. But this takes enormous amount of not just energy, but resources to be able to implement prospective review of blood. In the meantime, it's just you and I educating people around us in terms of what's appropriate when you care for patients. Screen, diagnose, and identify the disease, identify the etiology of the disease. We do that all the time in all other walks of medicine rather than respond to a number and give a therapy.
Excellent. Excellent note to end on. Thank you so much, Dr. Shander. At this time, I'm going to share our slide for CME. So those of you who would like to obtain continuing education credit, Please scan this code here. I'll also put it into our chat to ensure that if you're on your phone, you can still access this. But thank you all so much for joining us today. We so appreciate you, Dr. Shander. Safe
Thank
travels,
you.
and yes, wishing everyone an excellent rest of your afternoon and weekend ahead. Okay, have a good day.
Bye-bye.
Bye-bye.